hello. And yeah, so I'm Rebecca, and apologies from Sarah that she couldn't make it today. I'm going to talk to you today about KeMiST, which is a project that I worked on a couple of years ago, where Sarah was the PI, and I was obviously doing the research assistant. So KeMiST is Kent Medicine Support in Stroke and TIA. And today I'm just going to talk about the strategies for involving people in research post-stroke and some of the issues that we faced. So I'm going to talk about stroke and just a very brief description of some of the issues that can come up for people that might prevent them from taking part in research, and a little bit about the project, and then about the strategies that we used. So we were looking at stroke and TIA in the UK. So these are statistics from the Stroke Association website. We were looking at ischemic stroke, which is the most common form of stroke, and it's clotting rather than bleeding. And the reason for only looking at one was just because it's a different set of drugs, and we're coming at this from a kind of pharmaceutical perspective. And TIA is transient ischemic attack, which is sometimes called a mini stroke. So we're looking at those two things together. But you can see that this is a growing problem, and it's affecting more and more people. It's estimated that the stroke incidence is going to rise by 60% per year as the population ages and combined with other factors such as obesity. So it's a growing problem here. But as treatments have vastly improved the survival rates, there are an increasing number of people living post-stroke as stroke survivors in the UK. So currently that's over 1 million, but that's estimated again to double by the year 2035. So these are very common problems that you see more and more of. The issues that people can face can be physical, cognitive, or emotional. So in terms of physical, fatigue is extremely problematic, and everybody, no matter kind of how mild or how severe a stroke, suffers from this, and it impacts very greatly on their daily life and your ability to kind of carry on with normal tasks. Other physical issues can range from severe disability to very minor impairments, some permanent and others less so, but include muscle weakness, changes in sensation, which allow you to do daily tasks, and of course pain. So often people have to relearn to do very basic things, just making a cup of tea and walking and so on. Cognitive problems are common after stroke and include issues with attention and concentration, memory, perception. So that can be spatial perception, or your ability to judge distance or movement, which again can impair your ability to do things for yourself. Things like hemispatial neglect, which means that you're kind of not aware anymore of areas of your vision, and executive dysfunction, which is kind of the higher level programming of your brain. So that can stop you doing things like planning, problem solving, organizing, or kind of time planning, that kind of thing. So a lot of these problems are quite invisible. So people might have quite severe cognitive dysfunction post-stroke, but it's not obvious to people. And that can be both frustrating and also embarrassing for people just trying to go about, shopping and other basic tasks. And communication problems related to both of those, so that you can have kind of obviously facial weakness and muscle problems, which can affect your speech, so that you can't speak clearly, your speech becomes slurred or slow, often quiet, and it's difficult for people to understand what you're saying. Or aphasia, which is where the part of your brain that understands language and retains language is damaged. And so then obviously you're no longer able to understand or to use language as you were before. And there are degrees of that, of course, but about 1/3 of people post-stroke do suffer from some degree of aphasia. And that again, similarly, is a real barrier just to carrying on normal life and doing the things that you did before. And in terms of emotional issues, obviously it's very sudden, it's very shocking. A lot of people talk about kind of fear and anger post-stroke, and it's a very devastating change for most people. It affects your life, your family, your ability to work, your basic independence. For example, driving isn't possible, and think after a month, your doctor has to kind of allow you back in. So all kinds of things are quite challenging. And obviously in that circumstance, people feel vulnerable and emotional. And taking on medication, as well as these changes in your kind of physical abilities, is a challenge as well. And within that, some of the other issues, communication problems, cognitive problems, can make it more challenging to explain how you're feeling, even to your close family members, and that again can be frustrating. So a wide range of issues and problems that people can be faced with. KeMiST as a project was trying to speak to all of these people in order to get their views. And the main aim is to better support people taking their medication post-stroke. So people who've had a stroke are much more likely to have another. And one of the best ways to prevent that is with medication, so secondary prevention. But adherence can be a problem, and we know this. There are loads of factors to this, and part of our research was looking at some of those factors in more detail. So obviously some of the effects that I've just kind of whistled through there, but things like memory issues can affect your ability to take medication. A lot of people's ability to swallow is affected, and that will affect your ability to take medication. But even just kind of fine motor skills, so being able to take pills out of a blister pack or open a child-proof container can be extremely challenging. So there are loads of different issues, but linked to that, and similarly to other conditions, is just the acceptance of having had a stroke, particularly for younger people, and acceptance of the diagnosis and your willingness to take long-term medication. So there's a whole kind of complex web of things that we're trying to look at in order to see who's at risk of not taking their medication and what we can do to support them. So that was kind of the project. So the Stroke Association, who funded this, were very keen that we should not leave out people who were harder to interview or harder to get to take part in the research. So particularly people who did have some of the more severe cognitive or physical problems, and that they weren't going to be excluded. So throughout the project, some of these aspects were designed in, as I'll explain, and some of them were developed as we worked. So I'm just going to talk about some of these strategies and that we used to try to include people to participate as much as we could. So this is a very, very quick overview of the whole thing. So we started with questionnaires and then interviews, those were analysed, and the focus groups was kind of a fact-checking exercise. So taking it back both to people post-stroke as well as health workers to look at some of those results and see what we were coming up with. And then there was, so that was all kind of phase one, the research phase. Phase two was to design a tool, and in fact we designed two tools, which I'll show you in a minute, to support people. And those as well had to be accessible to the widest range of people that we could design them for. So I would say as well that there's a kind of strong PPI element that was embedded throughout. So from the very beginning, in terms of kind of oversight and stakeholder groups, and also people who were engaged in all of these meetings, in the focus groups, in phase two, we had two development days, and there are kind of various stakeholders and people post-stroke involved in those. We also had very strong partnerships and co-Is from both community and hospital trusts, and kind of really quite good engagement in terms of both oversight of the project, but also recruitment and kind of ongoing engagement in how the project was working. So we were quite lucky in that respect. So I'm just going to talk through the things that we did kind of one by one. So obviously the questionnaires were the first part of this, and questionnaires are obviously quite problematic for people with different abilities. This was quite a long questionnaire, which was problematic in itself, and included obviously demographics and things to do with how long since your stroke and how many medicines you're taking, taking also an adherence scale and the Living with Medicines questionnaire, which is a questionnaire looking at medicine burden across 8 different domains. So this was sent out through these different avenues. So we sent it out through DocMail, through GP practices, to try and get us as broad a coverage as we could. So that was off the GP list of anybody who's had a stroke. But obviously through the post, you can't control who will send that back, and it has a relatively low success rate. We also used the acute stroke services outpatient clinics, as obviously we're looking not for people as they're being discharged, but people who've been taking medication for a little while. But also the rehab services, and our kind of co-I organisation was Medway Community Health, who were brilliant, and who I shadowed their teams with and kind of really worked together, and they were very active in supporting us in recruiting people for this, but also recruiting on their own for people to do the questionnaires. The main kind of strategy that I would highlight today is using the support groups. So there are a lot of stroke support groups, some or mostly run by the Stroke Association and other independent ones across Kent and Medway. And this was an approach which worked extremely well. I mean, in terms of kind of the percentage return, it was something like 51%. But it did mean going to and attending lots of different stroke support groups, stroke communication groups, talking with people. We had some kind of large print cards made up to advertise the project, and spoke about it in front of the room and that kind of thing, so as to kind of acclimatise people to the project. But the main strategy, of course, is just being there and offering people support in filling in the questionnaire. So for a lot of people, actually holding a pen, reading the questions, sticking with it for long enough to do the two different scales. So actually just offering to read them the questions and fill it in for them really helped, and people really appreciated that. So we did get quite a good return rate overall, which was good. So I think in terms of what we would have done differently, this recruitment strategy was set from the beginning, and it's quite medical. So it's kind of coming at the perspective from people who have had a stroke, if you like. And I think with the benefit of hindsight, we would have included more community-based recruitment. And we did try to engage a bit further down the road, the U3A, which is the University of the Third Age, so retired people doing various courses, and also age concern, to try to kind of access a broader base of people who might not be specifically seeking out stroke support. And those were relatively successful, but we should have really started that from the beginning. What else? So, oh yes, the other thing I would say in terms of inclusion criteria, these were our inclusion criteria. So 18 years and taking regular medicines and living in your own home. So rather than a residential care home where they would take care of your medicines for you. The fourth criteria created problems because a lot of people said they weren't eligible and didn't do the questionnaire because when you've had a stroke and you live with your husband or wife, they say, no, my wife, my husband does it all for me. And actually that made them ineligible. But that kind of treatment dyad and that kind of reaction within the home, the way the family unit took on the treatment of stroke was actually quite an important dynamic, and something which we lost a little bit because of that, which again, with the benefit of hindsight, we maybe could have changed. So the interviews, and this again is something that's quite difficult to do. We interviewed 32 stroke and TIA survivors. We sampled them across burden and adherence, so to kind of take in those varieties. We tried to look at age, time since first stroke, things like that, to get a broad as possible variety of people. And of course, we also interviewed a purposive sample of health workers to kind of complement that. We did, in the research design, include dyad interviews. So we were able to interview people together with a carer. And interestingly, just as I said with the kind of treatment dyad and cooperation, it wasn't so much that they wanted their carer or their husband or wife there as support to take part in the interview, but actually that they were very much working together since the stroke had happened, and that was quite an interesting dynamic to record. So we work very closely with the Stroke Association, the local Stroke Association, and with their support and knowledge, we were able to design various strategies for the interviews. So we looked with them at our existing interview guide and really simplified the questions. So as a qualitative researcher, it's quite a difficult process to shut down into a series of closed questions what should be a kind of open interview. But you'll see some of the materials that the Stroke Association shared with us in the next couple of slides, and they were just different ways to try and enable people to answer the same questions by thinking through, so these resources matched to the different questions. We also did some practical things and obviously kept the interviews to a relatively short length. We offered people breaks, which some people took. And I think as a kind of reflection as the interviewer doing it, I think by offering support, by offering different resources, by offering and understanding that, you know, you might get tired and we're happy to break off, then people feel more comfortable just accepting the interview in the first place. So yeah, so I just stress again, you know, we didn't kind of invent this stuff, and we didn't have the capacity or the time within the research project to do that. So this is one example. I'm going to show you a bunch more. But we worked closely with the Stroke Association communication team who run communication groups. We went and visited those communication groups, and we sat with them and went through our questions and worked out some of these pictures which matched our interview questions in order to support people properly. So we had sheets like this. This is kind of days and times, and it's a kind of balance in practical terms of having these resources there. So things that people can draw on in order to answer questions about the frequency of taking medicines, about when they've taken medicines since, you know, when you're probing for timelines and trying to simplify it, just having a visual aid that they can then mark on, even just roughly, and having multiple copies in order to kind of facilitate that. But obviously not wanting to kind of overload them with bits of paper. So you have to kind of balance it in that way. We designed this so that we had props for every single question. In reality, people leaned on some and not others, and on the whole preferred to try to have a normal interview and to carry on speaking. But a lot of people did find it helpful to have some props there in the background for some questions. So for example, the time and things like that, depending on what they specifically might struggle with. And just having some paper and some kind of fat marker pens that are easier to hold there and available was probably the most low tech and the most useful thing that we did. How am I doing for time? Okay, I'll be quick. So
yeah, you're doing fine, Rebecca.
So this is just some examples again of the stuff that the Stroke Association shared with us. So some of these are kind of adapted specifically to our questions. So looking at different emotions, different levels of things, just being able to say yes and no without a lot of effort. And here again, thinking through the different emotions people might feel in terms of talking about their trajectory, as well as using scales, just keeps it a little bit less challenging for people who are struggling to vocalize and struggling to remember the words. In terms of interviewing, just as a kind of reflection, it's quite different interviewing like this, and you also have to be aware. So we, again, kind of with the benefit of hindsight, we might have redesigned the interview process so that we could use things like this as data. So for example, we were asking people how, with the wheel on the right, how their different kind of abilities or experiences had changed post-stroke, so before and after. But because we didn't have ethics to use this kind of thing as data per se, during the process of actually interviewing people, you have to be quite aware of saying things from the tape, if you see what I mean. So without making it sound like a police interview. So for the tape, the interview is nodding, but a little bit of vocalizing perhaps some of the non-verbal things that are also happening, just so you have a record. So that research was all kind of analysed, and those were the tools that we used to try and include people as much as we could in the research. And then we, using that, designed actually 2 tools and fitted them into the pathway. And that kind of process was part of that kind of shadowing everybody and spending time in all the different parts of the stroke pathway to understand how we could fit these things in properly. So tool 1 was actually who to flag for referral. So this was used at discharge, but we did still take it out to the patient groups, to the support groups, to talk through with them the different things and the different aspects that were being discussed. We also tested it out with the hospital discharge team, and they used it to kind of test it as well. So it's a kind of iterative process of coming up with these things, changing the questions according to people's feedback, and then kind of retesting. So this was tool 1, and this is actually a slide from one of our project meetings, and just the kind of discussion which is indicative of how we changed and reflected on the feedback that we were getting. And where it says positive reactions from both groups, so that's the groups of staff and also the groups of people post-stroke. So tool 2 was for people to use themselves. So this one was a much more, well, it's much more necessary obviously for people to be able to use it. So this is a paper version. And again, it's this kind of ongoing process of iterative design. And we tried out all kinds of different designs and fonts and sizes and so on. And again, with input from the Stroke Association, have long history of doing these kinds of things. This again is a project meeting slide. So just to give you an indication of the kind of, so we've removed a question because the people in the support group say it's irrelevant, it's too difficult. We've changed a question because it's difficult to understand, highlighting some of the words to make it clearer. And then getting reflections from them about where in the stroke pathway and when it would be useful to be asked these questions. So again, this was about design and ease of use. A lot of people can't read black and white, as we well know. That's a big issue. The kind of bumblebee one, the black and yellow, is for people post-stroke, was a very popular choice. And so we took these to all kinds of different support groups, so working age support groups, communication groups and support groups for people post-stroke, who all kind of iteratively looked at the different versions, looked at the questions. And we kept it as simple as possible, but there was, unfortunately not within the life of this project, the discussion of having a kind of pictorial version somehow. And of course, it would be easier to develop some of these kind of different colour versions on an online version or an app version. If any of you have ever been on the Stroke Association website, you can change the whole thing into these different colour combinations, which is quite good. We did, because we were looking obviously at a slightly older population, people living post-stroke, we added a question to the survey. So we went back to ethics. It was a little bit later on, because we realised that if we wanted to design an app as part of this, we needed to get a picture of who was using what kind of technology. So we actually changed the questionnaire and added this in. So only 75% of the respondents did answer, but we did get a relatively good sample of people in older age groups who were using the technology and therefore could access an app. And interestingly for us, people with the lowest adherence were more likely to use the technology. So that would have also been good for the app as well. So just to kind of sum up, I guess this was a process of kind of learning by doing for us as a research team, and certainly for me. A lot of it was really helped by face-to-face interaction, which is ironic saying at the moment, so apologies. But yeah, just by being there, helping people to fill in questionnaires, giving them support, that kind of thing. and giving people help and guidance as appropriate. So developing those materials to allow their participation. But again, not necessarily developing your own materials, but borrowing and leaning on the stuff that's already out there. And again, I'll just stress the importance of all those relationships that we had and fully understanding the pathway in order to fit this in. This all took a lot of time and a lot of legwork is my final point. I think in terms of doing any of this, and certainly some of the more successful things and that time in the support groups, yeah, you've just got to have the time and therefore the funding to be able to do it. So that's it. I hope I've stuck to time. Thank you.